already in chat. You can press 9 now. Okay. I've got a few more people coming in. I'll give it one more second here. Hello, Malind. He made it. Okay. I'm hoping everybody can hear me. This is our first attempt with this software, so we're hoping that it works well and that we're able to record this so that we can use it for educating people past this conference. I think we have a question here. Let me see how this works. I don't know where that went. Okay, got it. All right, I will address that at the end. All right, well, we are going to begin, and I welcome you to the HCMA's webinar series. I encourage you all to stay in touch with the HCMA because we're going to have several more programs coming up in the next couple of weeks. Today's topic is research in HCM, and we're going to be discussing CMR or MRI in HCM. In about 3 slides, we'll get to that. I wanted to, there we go. Wanted to give you a reminder that this webinar is for informational purposes only. If you have specific questions about your HCM, please discuss them with your HCM care provider. If you need assistance in finding a provider, the HCMA office is here to assist you. Please contact us and we'll make sure that you have some resources. In addition, I wanted to take the opportunity to remind you that the HCMA is currently conducting our general survey, which we do every several years. The link is available on the front page of our website. You can press on the icon here of the picture of the young lady, and you can take the survey. As of right now, over 1,400 people have taken the survey, and we are hoping to reach 2,000 by the end of the summer. So if you have not participated, please do now. So without further ado, I'm going to hand over the presentation to Dr. Chris Kramer, and he is going to talk to you about this project. Chris, you can take control of the presentation. And you have the floor. Uh-oh, I can't hear you.
Welcome, everyone.
Now I can.
Thanks for joining the webinar. The study I'm going to be talking to you today about is called HCMR, which is Novel Predictors of Prognosis in Hypertrophic Cardiomyopathy. It's an NIH-funded study. We were funded approximately a year ago, and the study is really just getting up and running. We recruited the first patient at the end of April. So as you know, HCM is characterized by hypertrophy of the myocardium, the heart muscle, also called left ventricular hypertrophy. It also is characterized by fibrous tissue in the heart that can be diffuse or patchy. And it's associated with disarray of the myocardial cells or myofibers. And there are subsets of patients who have a poor prognosis due to either the development of sudden cardiac death from fast heart rates or ventricular arrhythmias or congestive heart failure. And as you may know, that the clinical predictors that physicians use to predict adverse outcome are reasonable, but are also reasonably weak, and that this has limited clinical trials of new therapies to treat and prevent sudden cardiac death and treat and prevent the development of congestive heart failure in HCM. So we set out a couple of years ago to design a study to develop better predictors of these outcomes. So one of these predictors are findings that we can demonstrate on cardiac magnetic resonance imaging. So many of you may be familiar with cardiac MR or cardiac magnetic resonance imaging, but some may not. This is the image that's the movie on the upper left of the screen is a movie from a cardiac MR study in a patient with hypertrophic cardiomyopathy. What you see is what we call asymmetric septal hypertrophy or abnormal thickening of the septum shown here. I'm pointing it out with the arrow on my screen compared to the relatively normal thickness of the myocardium at the apex of the LV, and in this case the lateral free wall. On this image as well, we see the classic finding in obstructive HCM with what's called SAM, or systolic anterior motion, of this mitral valve leaflet, causing outflow tract obstruction here in the left ventricular outflow tract. That is demonstrated as that turbulent black jet of flow going towards the aortic valve. And that is associated in many patients with HCM with shortness of breath or chest pain with exertion, that outflow tract obstruction. With cardiac magnetic resonance, it's the most accurate way of measuring left ventricular mass, or the actual weight of the heart, the LV cavity volumes. We can also measure the outflow tract gradient in a similar way that echo does, and we can assess the leakiness of this mitral valve, so-called mitral regurgitation. This particular individual has very mild mitral regurgitation. So all of these findings, however, can be shown by echocardiography. So there are certain findings on cardiac MR that are novel and we think are associated potentially with the ability to predict outcomes to a greater degree. So the first finding is something called late gadolinium enhancement, a fancy term for a way of imaging scar in the heart. Essentially what we do is we inject standard clinical doses of gadolinium, which is the typical MRI contrast agent, and when we image about 20 minutes, between 10 and 20 minutes after infusing the contrast agent, in certain patients, areas of scar in the heart appear bright white as compared to the more normal myocardium or heart muscle appearing dark. So these are 6 different examples of patients with HCM. Patient A has no scar in the heart. The heart muscle looks black here. This is the heart cut like a bread loaf in the short axis. So you can see that the septum here is thicker than the other walls, but there's no bright white in the myocardium. It's all dark black. That signifies no late gadolinium enhancement, no scar. Here's a patient with an extensive amount of scar in the heart from HCM. Some confluent here, some patchy here. Here's patient C, has some scar classically found in HCM where the right ventricle and the left ventricle intersect. Patient D has these small areas of scar. Patient E has these small areas of scar. And patient F, who has marked increase in wall thickness here in the septum, has this sort of patchy, diffuse kind of scar in the heart. And so the question is the presence of any scar predictive? Is the amount of scar predictive? Is the location of scar predictive? And that's one of the aims of this particular study. We know from prior studies, this is a study published about 5 years ago, that just measuring the absolute size or weight of the heart, the left ventricular mass, is associated with predicting outcomes. So in this particular study, those patients with markedly increased weight of the heart, or LV mass, had worse outcomes over 5-year follow-up than patients with normal or only mildly increased mass. And as you may or may not know, cardiac MR is the most accurate way of measuring the mass of the heart. So that's another measure that we'll be making with this study. In terms of the predictive value of late gadolinium enhancement, our group at the University of Virginia published this meta-analysis of the 4 largest published studies to date. It's a total of almost 1,100 patients, showing, and in about 2/3 of whom had evidence of any scar in the heart, as shown by that technique I was describing earlier, late gadolinium enhancement. And what this meta-analysis that we published showed, that the presence of any scar just barely predicted cardiac death of any cause, didn't quite reach predictive value for sudden cardiac death, did predict heart failure death, and did predict death from any cause. So this is with close to 1,100 patients. The study that we're embarked upon is going to include 2,750 patients. We'll have the largest power of any study to date to really get to the bottom of whether the presence of scar is predictive, or it's more the amount or location of scar. You should be aware of another emerging concept that's been borne out in studies of cardiac MR in the last 5 years or so. This is the ability to image scar that we can't see with the naked eye. Previously, the only way you could see this scar is if you had the heart in your hands at autopsy. This is scar you can't see. It's a lacy fibrosis that's only visible under a microscope. But as it turns out, now we can image it with cardiac MR. It's a technique called T1 mapping. We can do it before giving contrast and then after giving contrast. We'll be doing it in the HCMR study. This recently published paper about 4 years ago showed that in HCM and in a valvular heart disease known as aortic stenosis, that there was a close correlation between the fibrosis that was measured by MRI on the x-axis and the fibrosis that was measured when a piece of the heart was taken at surgery, either in HCM, if the patient was having septal myectomy or part of the septum removed. That piece of the septum was looked at under the microscope for diffuse fibrosis, and the same was done in aortic stenosis. And when you put all the patients together, you can see that there's this very tight correlation between what was seen on MRI and what was imaged with the microscope, under the microscope. So we have a very valid way now with MRI of measuring this kind of fibrosis that previously was only visible with the use of a microscope. Now we can quantify this with cardiac MR T1 mapping, so measuring not only the fibrosis we can see or scar we can see with late gadolinium enhancement, but scar we can't see with the naked eye with T1 mapping. There have been some preliminary studies with T1 mapping. This study from the Brigham and Women's Hospital, which is part of our consortium in HCMR, that this measurement of diffuse fibrosis by cardiac MR, there were 29 patients with the positive gene for HCM, but without the phenotype, meaning the patients had not developed evidence on echo or MR of overt HCM yet. There were 37 patients with both the positive genotyping and evidence of HCM on echo or CMR. And you can see that their markers of diffuse fibrosis were elevated in both groups of patients, those without overt HCM by echo or CMR, and then even higher in those with overt HCM by echo or CMR. So we think this marker of diffuse fibrosis by T1 mapping may become an important marker of prognosis and outcome in this disease. I think many of you, or if not all of you, are familiar that this is a genetic disease. Generally, all the genes are autosomal dominant. Many are mutations in genes encoding sarcomeric proteins. One question that remains is, do sarcomeric mutations inherently cause an increased susceptibility to injury to the heart muscle and to scar, and hence to adverse outcome? And that's another of the questions that we'll be investigating in this study. There is some preliminary data that suggests that certain sarcomere mutations are associated with worse outcome, and this data from Olivato and colleagues published a few years ago showing that there's some tendency to worse outcome in patients who have a genotype that is myofilament positive as to those with a mutation that's myofilament negative. We will be studying many more genes in this particular study, and with a patient population of 2,750, we'll really hope to understand if there are genetic markers of adverse outcome. Another marker that will be being measured in this study are circulating blood biomarkers, one of which will be markers of collagen biosynthesis. This is a study, again, from the Brigham group of a marker called PICP, or the C-terminal propeptide of collagen. It's a basically a breakdown product of that's released into the bloodstream during the synthesis of collagen. Collagen is the sort of the building block of fibrosis or scar in the heart muscle. And so increased levels of this building block in the blood is a circulating marker of more scar in the heart. And so again, from the Brigham group, showing that patients with HCM mutations but without overt HCM by echo or CMR had modestly increased levels of PICP. Those patients with overt or echo or CMR evidence of HCM have an even higher circulating level of this PICP. And it's our thought that perhaps these biomarkers may be predictive of increased risk in HCM, and that's another aim of the HCMR study. Troponin, which is a classic marker of heart injury, is typically released in a heart attack, but levels can also be elevated in HCM. This study from the Japanese group, just published a few months ago, showed in a group of about 250 patients that higher levels of circulating troponin, in this case high sensitivity troponin T, which is a certain newly recognized biomarker, that elevated levels of this marker were associated with adverse prognosis in HCM, that patients with higher levels did worse than patients with lower levels. So this is another marker that we'll be looking at in the HCMR study. So I've given you a bit of background about the potential markers that we'll be looking for. Let me describe to you a little bit more about the study HCMR. It's entitled a U01. A U01 means it's a cooperative agreement with the National Heart, Lung, and Blood Institute. This means that members of the administrative staff of the National Heart, Lung, and Blood Institute and the NIH are very intricately involved in the planning and performance of the study. They participate in our weekly conference calls and are integrally involved in decision-making in this study. So you can see that NIH is very highly committed to seeing this study through and seeing this study be successful. We were funded almost exactly a year ago today. It's taken that much time to get all the paperwork done, get all the sites signed up, and all the paperwork at individual sites going so that we can get started. The goals of HCMR are the following. One is to change the existing paradigm in HCM by markedly improving risk stratification over and above the presently used clinical predictors. Number two is establish risk predictors to select patients for future clinical trials to prevent sudden cardiac death and prevent the development of congestive heart failure. Number three is to identify novel surrogate endpoints to monitor treatment response, whether they be imaging, biomarkers, or genetics. And number four is to establish the evidence base, definitive evidence base, to be able to design studies that will reduce morbidity and mortality in HCM in a cost-effective manner in the future. We proposed to the NIH, and we're lucky to be funded, a definitive observational registry of 2,750 patients with an established diagnosis of HCM. This is not a screening study. These are patients who will have the diagnosis made by their cardiologist, and either by echo or CMR, et cetera, or genetics. These patients will be enrolled over the next 2 years and will be followed up for at least 3 and up to 5 years, depending on where in the 2-year period they get enrolled. The average follow-up will be 4 years. We hypothesize that novel biomarkers identified by CMR or cardiac magnetic resonance can identify HCM patients with a higher primary outcome event rate. Number two, that those with sarcomeric HCM mutations will have a higher primary outcome event rate. And number three, that those with elevated levels of serum biomarkers will have a higher primary outcome event rate. So the aims of our study are as follows. We aim to develop a predictive model of cardiovascular outcomes in HCM by combining all the data that I've described to you that we will obtain and use exploratory statistical methods, so-called data mining methods, to identify demographic and clinical, meaning sort of your basic clinical markers, as well as novel cardiac MR, genetic, and biomarker variables associated with primary and secondary outcomes. I'll describe to you what those outcomes are in a moment. Putting all this data together, we'd like to develop a predictive model that can be used to assess risk given a patient's combination of risk factors. So you could go to your cardiologist, your HCM specialist. They could do a cardiac MR, genetics, and biomarkers, put all their data in a smartphone app, and tell you what your risk of sudden cardiac death over the next 5 years is, and what your risk of developing heart failure is over the next 5 years. And in using that predictive risk, then develop a treatment algorithm, possibly with novel therapies that can lower that risk. So as I mentioned, we'll be recruiting nearly 3,000 patients. The age that we're looking for are patients between the age of 18 to 65, established HCM diagnosis. We have enlisted 40 sites in, that should say North America, because we have some Canadian sites, North America and Europe, with dedicated HCM centers and CMR capabilities. I've already mentioned it's a 5-year study period. The endpoints that we're looking at, the primary endpoints, will be death from a cardiac cause, either sudden cardiac death or heart failure death. Aborted sudden cardiac death, that means if the patient has an ICD implanted after the initial study and it's noted that the ICD fired appropriately to prevent sudden cardiac death, that will be noted as a primary endpoint. And the third primary endpoint will be the need for heart transplantation. Secondary endpoints include death from any cause, fast heart rhythms, ventricular tachyarrhythmias that don't lead to sudden death, heart failure hospitalization, atrial fibrillation, which is another abnormal heart rhythm coming from the atrium rather than the ventricle, or stroke. So who can't be in the study? Patients that can't be in the study include those who've had a heart attack, so they have coronary artery disease. If they've had a heart attack, they're not a candidate. Those who've had prior surgery for HCM, either surgery or in the cath lab, so either a septal myectomy, part of the septum removed, or a so-called alcohol septal ablation in the cath lab where alcohol is injected down one of the heart arteries to create a heart attack and knock out some of the septum. If the patient has had either of those procedures, they're not a candidate for the study. Patients with known contraindications to cardiac magnetic resonance with gadolinium. So those include patients who have, at the present time, a pacemaker or defibrillator. They're not a candidate for the study because they can't safely undergo a cardiac MR study at this point. So only patients who presently do not have a pacemaker or defibrillator. Patients who are on dialysis with severe chronic kidney disease can't take part because gadolinium, the contrast agent we use for the cardiac MR, is contraindicated in those patients. Number 4, patients with fast heart rhythms all the time, ventricular tachycardia that's occurring regularly aren't candidates. Patients with diabetes mellitus with either kidney or eye or heart damage aren't candidates. And obviously pregnancy is a contraindication. So the timeline, as I mentioned, in the first 2 years we'll be doing all the patient recruiting, including the initial visit, which will involve about a 2-hour visit, including imaging and a blood draw of about 7 tablespoons of blood for the genetics and the biomarkers, and a questionnaire to gather all of the demographic and clinical information that's needed as well as acquiring some information from your physician about prior cardiac testing. The data will be analyzed in core labs that I'll describe, and then follow-up will ensue with yearly phone calls to ascertain how the patient is doing, find out about any events, hospitalizations, procedures, ICD placements, etc. And then years 3 through 5 will include the ongoing data analysis and continued patient follow-up. The MRI protocol will take between 45 minutes to an hour. Will involve these kind of images that you see on your screen, T1 mapping before contrast, the Cine imaging, which is standard imaging for structure and function of the heart. You see in this individual patient a markedly increased thickness of the ventricular septum here in the short axis. We'll do T1 mapping again after contrast, and we'll also do late gadolinium enhancement about 20 minutes after contrast. That's for looking for the scar that's visible to the naked eye, as shown in this individual, the bright areas within the heart muscle. The genetics will be drawn and sent to the core laboratory, which is at Oxford University in the UK, for next-generation sequencing. Complete coding sequence and flanking splice site sequences will be analyzed. In addition to standard sarcomeric recognized HCM genes that will be looked for, other clinically related disorder genes will also be examined for. A number of serobiomarkers will be measured and at the core laboratory for biomarkers, which will be at the led by Carolyn Ho at the Brigham and Women's Hospital in Boston. I've already mentioned PICP, which is a marker of collagen synthesis. We'll be also measuring markers of collagen breakdown. I won't go into the details here. We'll also be looking at markers of myocardial injury and stress, including the troponin that I previously mentioned, and a number of other biomarkers. So a comprehensive catalog of potential risk-identifying biomarkers. This is a schematic of the overall organizing structure of the executive committee of the HCMR study. I am one of the 2 co-principal investigators, along with Dr. Stefan Neubauer at University of Oxford in the UK. I'm in charge of the North American sites. Dr. Neubauer is in charge of the European sites. Dr. William Weintraub at Christiana Care Center for Outcomes Research in Wilmington and Newark, Delaware, is head of the Data Coordinating Center. Dr. Hugh Watkins at Oxford University is in charge of the Genetic Core Lab. Dr. Carolyn Ho at the Brigham and Women's Hospital in Boston is in charge of the Biomarker Core Laboratory. ICON Clinical Research is the clinical research organization that will be helping us with data collection and data analysis. Dr. Raymond Kwong from the Brigham is in charge of the Cardiac Magnetic Resonance Core Laboratories, and there are other investigators, some of whom you recognize, Melinda Desai from the Cleveland Clinic, Martin Marin from Tufts, who are all involved in the executive committee of this important study. There are 17 sites in the US, 3 in Canada, 11 in the United Kingdom, 3 in Germany, 4 in Italy, and 2 in the Netherlands. These are the North American study locations, and the list, I'll leave the list up for a few seconds for you to, I'm not going to read through them all. You can look for the one closest to you. We will have a website within the next 2 to 3 weeks that will be up and available. So if you wait a couple of weeks, you can search HCMR on the web and find the website and find the site nearest you. There are 3 sites in Canada as well, Montreal, Calgary, and Toronto. There are 7 sites that are presently recruiting. We're listed on clinicaltrials.org and .gov, and you can see which sites are presently recruiting. I will tell you that We at UVA, University of Virginia, are recruiting presently. Cleveland Clinic is recruiting presently. Tufts is recruiting presently. Stanford is up and running but won't be recruiting till mid-August. Yale is presently recruiting, and Oregon Health Sciences University in Portland, Oregon is presently recruiting. A number of others we hope to have, that's 6. Oxford should be starting to recruit next week, and several other, the North American study sites should be up and running in the next 2 weeks. We hope that all 20 sites should be up and running by the end of August. I'll come back to the question and answers in a moment, but in conclusion, HCMR, the NIH-supported study, has the potential to identify important new risk factors in HCM that will improve our ability to predict adverse events and identify targets for new and emerging medical and interventional therapies. With that, I'll thank you for your attention. I'm happy to answer any questions. I've listed a couple of potential questions here that I'll answer first and then open up to the audience for further questions. So the first asked question is, well, I live 3 hours away from a recruiting site. Is travel reimbursed? That is a question you'll have to ask the individual site. That's up to the site whether they have funds allocated for travel reimbursement. Number 2, I am not receiving my care at one of the named centers. Can I participate? Absolutely, yes. You don't need to be receiving care at that particular center. It's, again, a one-time 2 up to 3 hour visit, including the cardiac MR, the blood draw, and the questionnaire. You never have to return to the site again. All the yearly follow-ups will be phone follow-ups once a year for the ensuing 3 to 5 years.
Fantastic. Chris, thank you. I'm going to take back the presentation here, and I'm just going to scoot through. Excuse me, I wasn't ready for the technology there. Whoops, darn it. Just go that way. So I have a couple of questions that have already come in that I'm going to field to you. I'm going to stick with the study-related questions first, but we're going to go over a couple of non-study-related questions while we have them here. So the first question is, you kind of answered it, but we'll address it again. Can one get a CMR test anywhere? Can you just have it done at your local hospital and send it into one of the centers? Or do they have to go to the study site? And I'll let you answer that, and then I'll ask the second part.
Yes, the study can only be performed at one of the 40 sites. So in North America, one of those 20 sites. You can't have a CMR at your local hospital and have it sent in. The reason for that is the protocol is very, very carefully designed for this particular study. Some of the sequences that are used for the T1 mapping are research sequences and only available for use at these sites, and they're very specifically designed for the study. So the CMR and the blood draw must be done at the study site.
Within that same question, how do people get into the study? I guess what they're asking is there a double-blind process in this particular study? No,
this is an open study. You feel free to contact the principal investigator or any of the study investigators at any of the named sites. Again, if you go to clinicaltrials.gov and search HCMR, you will find the study. And under the list of sites will be the site you're interested in, and including the contact information, the email of the study principal investigator. So you can call or contact or email that site investigator and ask to be part of the study. Now, they may ask for documentation of your diagnosis. They may ask for an echo or records from your cardiologist just to confirm the diagnosis before they enroll you. But there's no blinding in terms of you contacting the study centers. the data is blinded. So once you enter the study, all the data is de-identified. So the core labs don't know, you don't have any record of your name. It's just a number. Your study, site number 7, patient number 126. So the data is de-identified, so it's blinded to those doing the evaluation of the MRI images of the blood findings.
Without going into the specific center, I think I've got 3 questions here. Can my center now get involved in being one of the programs involved with the study?
If at this point only the 40 centers, the 20 I listed in North America and then the 20 in Europe are members of the HCMR consortium. Because of the time it's taken to get these 40 sites up and running, at this point we are not looking for additional sites. We feel confident that each of these sites can recruit at least 70 patients. We have 40 sites recruiting 70 patients. That gets us to 2,800 over the 2,750 mark, and that's what we've asked each of these sites to recruit 70 patients. We really don't want to increase the number of sites any further because that will just delay getting those sites started. We're just at the point where we're hope to be up to 20 sites by the end of August and up to 40 sites by the end of September. So we really don't want to delay any further by adding additional sites.
We did answer this one question, but I will add to it. How do we contact each center? The website will be up in a couple of days or weeks. When Dr. Kramer has that data available, the HCMA will be putting that on our website as well, so you can just check into the HCMA under the Research tab. And there should be a link to their website, and that will have all the contact information that you'll need. Currently, you can see this trial on our Research tab on our link to clinicaltrials.gov, but it doesn't really give you the very specific phone numbers for recruitment purposes. That'll be on the website. Is that correct, Chris?
Well, at clinicaltrials.gov, actually, you can go in and look at the sites, and under each site, it will say whether it's recruiting or not yet, and it will say, give you the contact information for the principal investigator at that site.
Okay. My personal experience is those numbers sometimes get they get lost. Is that going to be the same number as listed on your website? Sometimes it's not the appointment desk.
Yeah, no, it's the contact information is for the principal investigator on the clinicaltrials.gov website. Okay.
So we'll try to get you a bit more specific information on the actual appointment desk.
If patients have particular questions, feel free to email me or one of the feel free to email me. ckramer@virginia.edu. If you can put that on the HCMA website if you'd like, Lisa. And so if there are site-specific questions, or how do you hook up with a particular site, I can certainly help facilitate that.
Fantastic. I have a couple of more general questions that I'm going to hit really quickly. Oh, wait, let's see. Oh, I'm sorry, there's one more study-related question. Will participants in the study receive reports or updates about their individual test results, or is that withheld?
The individual test results are generally withheld. Certainly, the images can be shared at the time of the study. The investigator, I'm sure, would be happy to review your particular images with you right there and then after your study is done. Many of the blood markers may not be tested till towards the end of the study, and again, they're blinded. So generally, those results aren't available to the patient enrolling.
So they would be able to get their images and their MRI data.
They'll be able to view their images.
Okay.
They won't be the analyzed results. Remember, the images will be sent to a core laboratory and then evaluated quantitatively separately. So it'll just be they'll be able to view their images if the investigator at their site is free to show them the images at the end of the study, but not the actual results of the imaging results themselves.
Okay, and then the biomarkers are de-identified and sent to core lab, so they're not going to be part of their medical records.
Exactly.
They're part of a research folder.
All of the data is part of this research study. Only none of it goes to the medical record.
In terms of reimbursement, if their insurance company does not pay for an MRI, does the study pay for the MRI?
Yes. So if the MRI, so many new patients just diagnosed with HCM may get an MRI as part of their clinical care, in which case that initial MRI, they can be entered in the study, and that clinical MRI can be used as the entry MRI in the study as long as it's done at that center with the proper sequences used. If a patient's previously had an MRI, say 6 months ago, again, that clinical MRI won't be done in the way that we need it to be done. So another MRI to insurance.
We've kind of addressed this, but I'll let you have it again. Will my local cardiologist have access to the images or data collecting if he's not a study site?
No, the data is not available to your physician. Again, the data is all de-identified and sent to the core lab.
So I want to pause here for a second because it's been a really long time since we've had a large-scale clinical trial in HCM, and a lot of the patient population is a little unaware of the differences between clinical care and a research protocol such as this. Can we just discuss for a minute where that data goes? It is a HIPAA-secured environment, and that their data is protected. But just talk for a minute about de-identifying data versus a clinical file.
Yeah, so if say your name is John Doe, and you enter the study at site number 3, and your patient number 52 at site number 3, you enter the study as John Doe, but your data, your MR images, your blood is identified as site 00. You'll have a number 003-052, meaning Site 3, patient 52, and that will cannot be linked to your name. Once the data is de-identified and becomes numerical, and then it becomes part of the data within the entire study and doesn't go to your medical record, is not linked in any way to your medical record. It will be forever as part of the database for the HCMR study as 003-052.
Thank you. I think that would answer some of their questions. The rest of the questions that I have here, I'm going to just quickly go through. They are more HCM general-related questions. One person asked if BMI is related to prognosis for HCM. I'm going to state that high BMI is associated with a lot of complications for cardiac disease, and you should discuss your personal BMI with your personal health care provider to see what it may mean for you. Additionally, somebody wrote in here a very interesting question about family history of HCM in an 80-year-old and a sudden death of a 20-year-old or 19-year-old nephew. I would ask you to please contact the HCMA office at 973-983-7429. We would be happy to discuss that case with you. If your family has not undergone genetic testing yet, there might be some programs available through the HCMA that might assist you in identifying the genetic marker in the deceased individual. So please do contact us. And that is about it for the questions. So I'm going to wrap up the call. I'm going to thank Dr. Kramer for his time explaining this program to us and tell you all that this webinar will be made available on the HCMA website and hopefully on YouTube, hopefully by the end of the day, technology not getting in my way. So I thank you all for your time and attention, and Dr. Kramer, thank you again.
Thank you all.
Bye-bye.
Bye-bye.